Greetings to all. Today I am going to talk about effortless economic microhook ab intendo trabeculotomy. I have no financial disclosure. As all we know, the Otto Borken have described the goniotomy in 1936. In this procedure, he cut the trabecular meshwork by using the knife. Goniotomy described as incisional goniotomy and axial goniotomy. Older ancient goniotomy, we cut the trabecular meshwork or give the incision by using the knife or MBR blade. The problem with this procedure, inability to lift the trabecular meshwork, and they are tend to close by the scarring. But newer goniotomy, like the axial goniotomy, by using specialized blades like the KDB, trabectome, or the microlot, in this procedure we elevate and excise the trabecular meshwork to assess the multiple collector channel. So most commonly performed TM-based procedure are the GAT, KDB goniotomy, microhook trabeculotomy, epsilon goniotomy, or bent ab interno goniectomy. Out of these TM-based procedures, GAT has the good promising outcome, but problem with this GAT is has a steep learning curve, and this is always associated with a postoperative hyphema. Then coming to the KDB and the eye stent, they produce meaningful IOP, but again they are very expensive in nature. Coming to Bang have the safety profile and efficacy is questionable. It has to be done by the 26 gauge needle. So really it is the procedure we have to be very careful when starting with the first procedure as a Bang. So why Taneto microhook trabeculotomy? Because it is efficacious, easy to learn, and very economic, and has the very good safety profile. It can be done as a first surgery for beginning of the MIGS. Coming to the Taneto microhook trabeculotomy, this is a simple procedure in which we cleave the trabecular meshwork and inner wall of the Schlemm's canal, thus reducing the resistance to aqueous flow. These are the three instruments, one is straight on the right hand side and left hand side. So if you compare the rest of the instrument with Taneto microhook, these are thin and slender. It's more like the Sinskey hook, but tip is specially designed which is used to cleave the trabecular meshwork. If we compare the area of treatment and compare the rest of the goniotomy procedure, microhook give the opportunity to incise more than 1/2 to the 2/3 of circumference of the trabecular meshwork, apart from the 360-degree GAT. So as seen in the picture, with GAT we can cover the 360-degree, while microhook trabeculotomy we can treat area up to the 180 to 240-degree. Here we are showing the right hand side and left hand side microhook. So right hand side is inside the supranasal, while in the left hand side the infranasal hook as seen in the shown in the video. After completion of the phacoemulsification, lens stocking was done, AC infrared with high density viscoelastic, and the microhook has been introduced into the anterior chamber and cleave the trabecular meshwork. As you see, this bony white line is showing the back wall of the Schlemm's canal, and similar way, sitting to the opposite side, we can treat the temporal area. This is similar way, microscope turned and inferior angle has been treated. At the end of the procedure, we introduce this trypan blue. You can see the trypan blue extend the nicely the aqueous vein is demonstrating the successful of procedure. We thoroughly wash the anterior chamber, and while making AC we can see the blanching of the blood vessels. Similar way we can perform CN pseudo exfoliation glaucoma also. So after completing the phacoemulsification, here we can see that's a pigmented trabecular meshwork. This procedure is much easier in pseudoexpression glaucoma. We can see here we introduce the microhook and we see the nicely cleaving of the trabecular meshwork. You can see the back wall of the Schlemm's canal. Then through the same, either you can use the side port or the main port to introduce the microhook and complete the procedure. Now coming to this, the so simple procedure, we can perform the microlot in the angle closure cases also. Removing the, after doing the phacoemulsification and IOL implantation, hook is introduced into the anterior chamber and we can cleave the trabecular meshwork by using the microhook. But I especially suggest the people who are well versed in the open angle, then only to perform these procedure in the angle closure cases. Microscope tilted and we can treat the inferior angle Antechamber burst and antechamber is formed. Microlot can be performed even in the difficult situation where colectomy and the tube surgery is difficult to do. Challenges of performing combined surgery in acute angle closure is known to all. Microlot is going to help in this situation. So this is the case of the acute angle closure glaucoma, in which the phacoemulsion was performed. Adequate size of the pupil had been obtained by using the stretch pupilloplasty, and routine phacoemulsification was done. Though there is a little bit challenging situation because of the high pressure, viscoelastic has been used over the cornea, lens was docked, and AC was filled with high density viscoelastics, and through the side port micro had been introduced and trabeculotomy was done. In this situation, especially the cornea is little bit hazy, so the view is not clear, but we have to put in high magnification and perform the trabeculotomy. This is the case where the glaucoma has been associated with iris coloboma. Performing a combined surgery or the tube surgery is very challenging. So in this situation, we perform the phacoemulsification with help of the iris hook. After performing the phacoemulsification, lens was docked over the cornea and trabeculotomy has been performed, and you can see the posterior wall of the Slem's canal is stony white. In this scenario, we can easily perform this glaucoma surgery to get the adequate IOP control. This is the case in which my fellow has been did the deep dissection and got the skull disinsertion. To rescue this situation, we perform the temporal clear phacoemulsification. After performing the routine phacoemulsification, we plan to do the microhook trabeculotomy. Lens has been docked, microhook introduced through the main tunnel, and cleave the trabecular meshwork right hand side, and similar way we cleave again, we put the viscoelastic in to maintain the chamber, and other side microhook trabeculotomy has been performed. So in this scenario, microhook can be used in the situation where we not able to perform the trabeculotomy due to the various complications. So this microhook trabeculotomy is a great rescuer in challenging situation. We did one prospective randomized study in combined phacoemulsification with ab-initio trabeculotomy in Indian population. In this prospective study, we randomized patients into phaco versus phaco-Taneto group. Each group has 57 patients. At the end of 12 months, phaco-Taneto group IOP reduced from 26 to the 12 mmHg, while in a phaco group 20.5 to the 20 mmHg at the end of 1 year. Looking at the anti-glaucoma medications in phaco-Taneto group, medication reduced from 0.6 to the 0.2, while in the phaco group it's 1.4 to the 1.1. So there is no major safety concern except the few hyphema into the phaco-Taneto group. Kaplan-Meier survival curve showed there's a good, complete and qualified success into the phaco-Taneto group in compared to the phaco group. The various studies have shown the effectiveness of the micro-hook trabeculotomy. Midterm outcome of micro-hook trabeculotomy in 560 eyes by assessed by the Masaki Taneto. In the study, the preoperative IOP from 20 to reduced to the 13.9 mmHg at the end of 3 years. Looking to the IOP reduction, 31% IOP reduction and 11% of the anti-glaucoma medication reduction at the end of 3 years. This is another study where they compared the non-infective microhook and compared to the trabeculotomy is called as a tram-track study. In this study, surgical success rate at 1 year after the surgery was 71 and 74 patients who underwent trabeculotomy or microlot surgery respectively. Microlot at 1 year was not inferior to the trabeculotomy. Hyphema and IOP spikes are the most common complication of microhook trabeculotomy. Usually the hyphema are the self-resolving and doesn't require any intervention. So just to conclude, combined phacoemulsification with ab-interno microhook trabeculotomy is an efficacious and safe procedure with mild to moderate open angle glaucoma. It significantly reduces the intraocular pressure, improves the visual acuity. It may be a valuable MIGS addition to the glaucoma surgical armamentarium. Special thanks to Masaki Tanito, inventor of Microhook. I got opportunity to meet and learn from him. And this is my team. Thank you.